Hello everyone. Today I will be speaking about celiac plexus and splanchnic nerve block. This presentation I had prepared for a PG oriented CME which was organized by SSP Karnataka on July 5th, 2025. So this topic is one of my favorite topics for two different reasons. Um, it is one of my favorite nerve blocks, and there are two other reasons why I I'm fond of these blogs because which I would like to state at the end of my presentation. So, coming to my presentation, celiac plexus and splanchnic nerve blocks are commonly performed interventional pain procedures, and they are used interchangeably for the same conditions many a times, and commonly done by many pain physicians. It is one of the most gratifying procedure which gives a lot of satisfaction and good relief for the patients. These are usually indicated for patients with upper abdominal visceral pain, especially pancreatic pain malignancies, other abdominal cancers such as cancers arising from the lower end of the esophagus, stomach, liver, spleen, from the foregut up to the ascending colon. It is also favored for many benign conditions such as chronic pancreatitis and some benign conditions where the condition, like the reason for the pain is either from coming to diagnose whether the reason for the pain arising is whether it's from the somatic structures or from the visceral structures. It is used as a diagnostic block. So it's done how whether the celiac plexus is used or splanchnic nerve plexus is used. They are used more uh, interchangeably for the same conditions. So before we go to the procedure per se, it's necessary that we know understand the contraindications. Just like in any nerve block, the common contraindications are local systemic infection, coagulopathy, patient who is receiving any anticoagulants, there is any abnormalities or bowel obstruction, if there is any intra-abdominal infection. It is also necessary to understand these many of these blocks are sympathetic blocks and autonomic blocks, which can cause hypotension because of systemic vasodilatation. And as it's necessary to especially be careful using in patients who have hypotension because it will definitely cause some amount of hemodynamic instability following these procedures. And patients who are unable to lie prone, patients who refuse the procedure should not be chosen for these blocks. It is also necessary to understand that anatomy is very 3D anatomy is very important in these procedures. So if there is any abnormality, it's necessary to go through the CT scans. If there is any abdominal aortic aneurysms, if there is a large tumor which is extending to these plexus, it's necessary to understand that it will be very difficult to do these procedures. Though it's not impossible, the procedure may not work, or it might be very technically difficult to do these procedures in such cases. So coming to the splanchnic nerve, splanchnic nerves plexus is usually formed by three different nerves. That is the greater, lesser, and least splanchnic nerves. So the greater splanchnic nerve is formed from T5 to T9, whereas the lesser splanchnic nerve arises from the sympathetic ganglia from the T10 to T11, whereas the least splanchnic nerves arises from the T11 to T12. All of these splanchnic ganglia arise from this sympathetic chain, which is lies on the paravertebral gutter, and they join together and coalesce together and anterior to the L1 vertebra, where they form the celiac ganglia. So it is necessary to understand the relation of these splanchnic nerves to the various vital structures. So as you can see, the splanchnic nerves are related anterolaterally to the pleura, medially to the vertebral body, anterior anterior to these sympathetic chain lies the posterior mediastinum, and caudally lies the crura of the diaphragm. So these greater, lesser, and least splanchnic nerve all join together, travel for a variable distance, and join together and unite in the celiac ganglia, where they relay and they supply the various structures as I mentioned earlier. So, as you can see in this diagram again, these splanchnic nerves supply all the vital structures such as the liver, spleen, and the stomach through the greater splanchnic nerve. The lesser splanchnic nerve supplies the small intestine and the foregut up to the ascending colon, whereas the least splanchnic nerve supplies the kidney and the surrounding structures. They relay through either the celiac ganglion or the superior mesenteric ganglion or the various other plexes located in and around the celiac ganglion. So coming to the splanchnic nerve block per se. So splanchnic nerve block is done mostly bilaterally, and usually in most of the conditions it is done bilaterally because of both the nerves coalesce together in the celiac ganglion, unless there is some anatomical difficulty. It can be done both fluoroscopically and under CT guidance. However, to my knowledge, it cannot be done under ultrasound guidance. So I will be highlighting first what are the steps of splanchnic nerve block, and then I will demonstrate a video where we have done splanchnic nerve block. In the fluoroscopy, the T11 and T12 vertebra are identified and squared in AP view. That is, squaring means the lower vertebral body appears like a straight line. C-arm is then turned obliquely on one side, on which side you want to perform the block, to visualize the costovertebral angle. That is the angle formed by the rib on one side and the vertebra medially. If the space is not visualized, a slight caudal tilt is done so as to identify the angle. If still not visualized, it can be done above the vertebra also. So after local infiltration, I show before I go ahead, these all procedures are done always under local anesthesia because we need the patient to be awake to tell us whether the drug has worked, whether the diagnostic block has worked. So after local infiltration is injected, a 22 gauge needle is introduced and advanced in an anterolateral aspect of the T11 or T12 vertebra to touch the costovertebral or lateral vertebral body. The final tip position should be in the anterior one-third of the vertebral body on lateral view or the lateral vertebral margin on AP view. So the dye is injection to identify a homogeneous paravertebral split and also to exclude aberrant spread. A diagnostic block is given with local anesthetic, and then the steps are repeated on the opposite side. So this is a video showing the splanchnic neurolysis for chronic pancreatitis. So as you can see, the dye lies on a homogeneous spread, shows a homogeneous spread in the paravertebral gutter at T11, T12 level, and in the lateral view, it lies in the anterior one third of the vertebra. Coming to the celiac plexus, so these greater, lesser, and least splanchnic nerve invariably travel through the posterior mediastinum and travel together and cross the rura of the diaphragm and coalesce in the celiac ganglia. These celiac ganglia are a pair of ganglia lying in front of the L1 vertebra. The size varies. Sometimes it is almost 0.5 centimeter, as small as 0.5 to up to 4.5 centimeter, and they lie at various distances. Sometimes it is at T11 level, sometimes it is at T12 level, and in some cases it is even found up to L2 level. So it's quite a huge ganglia compared to the other sympathetic ganglia, and it lies in front of the aorta. So it acts as a relay center to supply the various other plexes which are interconnected to it. So as you can see again, these are the sympathetic splanchnic ganglia which are joining together, and as you can see, it lies almost 1 centimeter in front of the vertebral body. in front of the aorta. Coming to the relationships of the celiac ganglia, you can see it lies in front of the aorta, where especially where the celiac artery emerges from the celiac artery in the left gastric, celiac trunk emerges from the aorta, and it is related lateral to the inferior aortic cava on the right side, and it is related to the kidneys laterally and the pancreas anteriorly. So it is important to understand that where the final position decides whether it's a you are actually performing a celiac plexus block or a splanchnic neurolysis. So if the needle lies posterior to the crura, it is called a retrocrural celiac plexus block. And if the needle lies anterior to the crura, then it is a celiac plexus plus classical celiac plexus block. So uh, they are the celiac plexus are a group of plexus which supplies the various organs, and the how you perform the block. There are since it lies close to various structures. There is different ways of blocking the celiac plexus. So celiac plexus block can be done either by classical approach or it can be done by a single needle transaortic approach. Celiac plexus by classical approach is done using bony landmarks, and it needs surface landmarks to be made, and it involves bony contact. Whereas in transaortic, there is no need of bony contact. See, these are rarely done nowadays. This classical approach, landmarks are identified, and surface landmarks are identified, and it includes marking the midline, the 12th rib, and the vertebral body. After skin preparation, T12 and L1 is identified fluoroscopically. Now, in this, there are two types. One is posterior retrocrural approach, where the skin entry point is marked about 6 to 8 centimeters lateral to midline, just inferior to the 12th rib. Whereas in anticrural approach, a triangle is formed by a line joining from the inferior border of the L1 vertebra, intersecting the 12th rib along the tip of the L1 vertebra. The height of triangle should be less than 2.5 centimeter. So here is the triangle. So this triangle is drawn and an entry point is taken just medial to this triangle and directed in a 45 degrees angulation this way. 45 degrees angulation towards the L1 vertebra. So after a skin infiltration is done, a long spinal needle is inserted and advanced approximately 45 degrees medial encephalite trajectory to contact the anterolateral L1 vertebral body. So you are trying to search where is the vertebral body. And once you touch the vertebral body, then you walk off it and advance it 1 centimeter into the anti-crural space. So needle placement is again confirmed with contrast pad around the celiac ganglia lateral to the aorta. So procedure has to be repeated on both sides, and bilateral placement improves spread. Although unilateral can suffice, but bilateral improves the spread. So final needle position is confirmed in AP lateral views by injecting contrast. So these procedures are rarely done. Now there is usually celiac plexus is done by a single needle transaortic approach, where a cephalocaudal tilt of the C-arm is done to square the L1 vertebra. A left oblique tilt, usually it is done only on the left side. Left oblique tilt is completely done to obliterate the transverse process. That is, the transverse process should enter into the vertebra, and a triangle is visualized formed by the rib laterally, the L1 vertebral body medially, and an imaginary line from the inferior border of the L1. So this is the triangle. There is a triangle from the vertebral body and the rib and an imaginary line. So a 15 gauge, 15 centimeter, 22 gauge needle is inserted in tunnel vision in the center of the triangle, slightly more towards the vertebra. Now the needle is advanced in lateral view. Intentionally puncture the aorta with dye injection, continuous fluoroscope. So continue to proceed until there is no longer vascular intact and the dye lies anterior to the aorta. The end point is in lateral view. The needle should lie anterior to the vertebra and the aorta, and in the anterior posterior view, the needle should be on the midpoint of L1. It is a single needle technique and we need not repeat it on the right side. So this is a video of a celiac plexus block. as you can see, the needle should lie anterior to the L1 vertebra in AP view, whereas in lateral image, it should lie almost 1 centimeter, more than 1 centimeter in front of the aorta. There should be no vascular uptake when the needle is anterior to the aorta. So we should keep in mind that when we are performing the celiac plexus block, by this approach, there should be absolutely no coagulopathy because we are intentionally puncturing the aorta. So ultrasound guided celiac plexus block is also a boon where we do these procedures for especially patients who can't lie prone. And the procedure is very simple. You place a probe, a curvilinear probe, just inferior to the aorta in a longitudinal axis. Identify the origin of the celiac trunk from the aorta, and then turn it, um, short axis to again identify the celiac trunk arising from the aorta, and the needle is just placed in front of the aorta. This procedure is very helpful, especially in patients who can't lie prone, and especially in patients who have any problems in the anatomy in the back, or they have any congenital anomalies, or there is an infection in the spine, posterior aspect of the spine. So, whether this diagnostic, therapeutic, or neurolytic depends on the procedure on which you plan to perform the procedure. So, usually for benign conditions like chronic pancreatitis, only local anesthetic and steroid is given, whereas for a malignant condition like as cancer pancreas, we usually administer a neurolytic block. Um, uh, in the beginning of my presentation, I said that this topic is my one of my favorites because it gave me my first publication in pain medicine, where I published a case series of fluoroscopic guided neurolytic splanchnic nerve block for chronic pancreatitis pain, especially those with refractory pain. And also that this was the initial blocks I used to perform very commonly when I which drew me towards pain medicine. The complications are many, and unless due precautions are taken, unless help is taken and expertise, you develop expertise in these procedures, complications are common. However, with experience, the complications are very minimal. The most common complication, however, you should expect in most of these cases is hypotension and diarrhea, which usually occur, and it is transient. And if adequate precautions are taken, these two complications are usually transient and manageable. So, take-home message is celiac plexus and splanchnic nerve block are highly recommended interventional management options in management of upper abdominal visceral pain. A strong grasp of anatomy, careful patient selection, image-guided technique, and a knowledge of potential complications is needed to succeed in this highly rewarding interventional pain procedure. Thank you.